Greeting, I am Dr. Amr. I will discuss to you today airway evaluation and management. Airway evaluation management is an important subject that every health provider should know how to do it. It gained special importance those days with coronavirus pandemic. What you will learn, we will review the anatomy relevant to airway management, which we already did, and we will understand the component of an airway examination and learn the principles of mask ventilation and intubation. Airway assessment starts with history. Any history of difficult intubation in the prior surgeries. Usually if the patient did surgery for the first time and we see it's difficult intubation, then we record it and we put it on a card, give it to the patient and tell him whenever you receive anesthesia, show the doctor this card. Okay. Also, if the patient had radiation because of CA or had surgical history near the airway, also may we intubate the difficult airway. Burns, especially burn in the neck, around the mouth, burn of the face, all this may lead to scar tissue later and difficult intubation. Swelling, tumors, masses around the airway, near patient face, all those may anticipate a difficult intubation. Patient with history of snoring during sleep, this also may draw our attention to could be difficult airway management. Patient with TM joint dysfunction, patient with problems with phonation, and history of C-spine disease, patient with rheumatoid arthritis, Down syndrome, disc disease, osteoarthritis, all those may lead to difficult airway management. On examination, we examine the cervical spine mobility, temporomandibular joint mobility, prominent incisor teeth. We examine the patient teeth for cups, disease teeth that may fall during the procedure. Also, we ask the patient to open his mouth and we see his ability to visualize his uvula, which we'll discuss this later. Also, thyromental distance. There are many methods for examining patient before trying airway management. One of the methods is Malampati test. Malampati test, we ask the patient to sit in the front of the examiner and in the same head level. We ask him to open his mouth as much as he can and protrude his tongue outside the mouth. Now, if we can see the whole uvula, facial pilaris, soft palate, so this is class 1 easy intubation. Class 2, we cannot see the tip of uvula. We can see the uvula, but not the tip. We can only see the base of uvula, facial pilaris, soft palate, and hard palate. So this is a class 2, which is intubation also possible with some manipulation. Class 3, when we cannot see the uvula at all, we just see the soft palate and the hard palate. And this is difficult intubation. We have a special instrument called difficult intubation instrument that we use it in such condition. Class 4, when you can see only the hard palate, and this is very, very difficult or impossible intubation, and maybe we need to do some procedures, invasive procedures, for example, retrograde intubation, cricothyroidotomy, other method to do endotracheal intubation. This picture shows you Malampati, and in this class 1 we see the patient, we can see patient uvula, full uvula, also soft palate and hard palate, while in class 2 we cannot see the tip of uvula but we can still see the uvula, soft palate, heart rate. In class 3, we can see the uvula. Only soft palate and hard palate. And class 4, this is another picture. Again, class 1, we can see the tip of uvula, soft palate, hard palate. Class 2, we can see the base of uvula, soft palate, hard palate. Class 3, which is difficult intubation, we can see on the soft palate and hard palate. Class 4, which is very difficult on a possible intubation, we can see only hard palate. How we anticipate difficult intubation by patient examination? Just by looking to the patient or asking to do simple movements, we can anticipate difficult intubation. First, we can see the patient teeth. If he has a long teeth, long incisors, we call it rabbit teeth, we anticipate difficult intubation. Relation of maxillary and mandibular incisors during normal jaw closure. That means if the patient we ask him to close his mouth, and we see if there is jaw recession or jaw is going backward because of micrognathia or just maybe another disease, and so expect difficult airway management. Or when we voluntarily ask the patient to protrude his jaw, and this is a test, we call it upper lip bite test, by asking the patient to try to bite his upper lip with his lower teeth. So if the patient can bite all his upper lip, this is class 1, which is easy intubation. If the patient can only bite the middle of his upper lip, this is class 2, and class 3, the patient can only bite a little of the upper lip. Inter-incisor distance, that means mouth opening, how much the patient can open his mouth. If he can open his mouth more than 2 fingers, so it could be easier intubation. If less than 2 fingers, could be difficult intubation. Visibility of the uvula, as we discussed before. If we can see the uvula, it could be class 1 or class 2 manipulopathy, which is easier intubation, or difficult intubation when we cannot see the uvula when class 3 and 4. Shape of the palate, if it's highly arched or narrow, it may be difficult intubation. Compliance of the submandibular space, if it's stiff, indurated, occupied by mass, or any other things there, any other masses there, or pathology, this all may lead to difficult intubation. Theramental distance, if we can put 4 fingers or more than 3 fingers, 4 fingers below the patient chin, between the chin and the thyroid cartilage, that means it could be easy intubation. If less than 3 fingers, could be difficult intubation. Length of the neck, if the neck is short, we anticipate difficult airway management, difficult intubation. Thickness of the neck, if the patient collar size more than 17, this may lead to difficult intubation. Range of motion of head and neck, patient cannot touch tip of chin to chest or cannot extend neck, also we expect difficult intubation. Airway devices. We start by simplest instrument, which is oropharyngeal and nasopharyngeal airways. Oropharyngeal and nasopharyngeal airways typically inserted when the patient loses his consciousness in anesthetized patient or deeply comatose patient, and there's a loss of upper airway muscle tone. So the tongue will go posteriorly against the postpharyngeal wall and will obstruct the upper airway. So those instruments is to open push the tongue away from the posterior pharyngeal wall and open the airway. How we anticipate the size, or how we measure the size of course it comes with different sizes. So for the length of nasopharyngeal airway, we measured from the nares of the patient to the ear meatus or earlobe. And oropharyngeal from the patient mouth angle to his same side earlobe. Now, oropharyngeal airway can be easily inserted. It's easy to use, but it's a problem that it cannot be accepted by semi-conscious patients. If you force it inside patient mouth, the patient may develop laryngospasm. While nasopharyngeal more acceptable by semi-conscious patients. But it is not acceptable to be used in patients suspected with basal skull fracture or patients on anticoagulant or anticipated coagulopathy. Those are different sizes and colors of oropharyngeal airway. We call it Goodall airway. It comes with either transparent, white color, or sometimes black color, okay, with different sizes. That's how we put oropharyngeal airway. We put inside the mouth, upside down, and we rotate it inside patient mouth. Those are nasopharyngeal airways. Mask ventilation is important when the patient cannot breathe, so we need to use mask ventilation. Mask ventilation facilitates O2 delivery, so we can get oxygen through them. Mask ventilation, and also anesthesia gases. The mask ventilation is not just like oxygen, ordinary oxygen mask that's used for oxygenation. No, mask ventilation is a special mask that can be put in against patient face and will surround the nose and the mouth of the patient. With airtight seal, we can ventilate the patient with ambu bag or any means of ventilation. There are two techniques for using this mask. One hand or two hand technique. One hand technique, by one hand we cross the mask and fix it on patient face. By the other hand we can use it for ventilation. How we do that? We put our thumb and index finger as C-shaped letter on the mask, and the other three fingers as E letter below patient chin, and fit it very well. And at the same time try to thrust the chin, that's when you pull the chin to the front, so the tongue will not obstruct the airway. This is one hand. Sometimes we can't control the patient by one hand, so we use two-hand technique. Two-hand technique, either by both hands, C around the mask and E by patient, or we can use the thumb to fix the mask on patient face and elevate the jaw by the other fingers. A dentures patient without teeth, maybe it's easier to keep the dentures in, especially it's full denture, or we remove it and put oropharyngeal airway instead. This picture shows how to catch the mask. This is C around the mask, and this is E below the chin. Another picture, C around the mask, E below the chin. This is one-hand technique. This is two-hand technique. Now, difficult mask ventilation. Maybe you cannot control the mask by one hand and by the other hand. If we are single-handed, we will call for help. So call for help. Anyone can help you, even patient or non-medical personnel. They just can grasp the mask very well with two hands and let your assistant to squeeze the back. Also insert a oropharyngeal nasopharyngeal airway. Extend the neck and try to rotate it by sides and perform jaw thrust. Laryngeal mask airway. This is another instrument for managing airway. We talked about airways, oropharyngeal, nasopharyngeal airways. Now we talk about laryngeal mask airway. Laryngeal mask airway is disposable, simple instrument. It consists of this cuff and this opening. This opening will be against glutic opening or laryngeal opening. And this tube extends outside the patient's mouth, and here interstitial connection can be connected to any interstitial connection ventilation like ambu bag or a ventilator. The cuff will be inflated, so most of the air will go to the larynx, then to the trachea and lung, and prevent the air to leak around and get out to go elsewhere. Of course, we have different sizes of this laryngeal mask. Insertion technique: patient placed in sphenic position, that's in supine position, face up. Deflate the LMA, cuff lubricated, then inserted blindly. Then inflate the cuff to create a seal around the entrance to the larynx. Try to pull and move the laryngeal mask inside patient mouth until it fits in its position. Then how we know it's in correct position? By inflating the connect the ambu back to the LMA and inflate the lung. If you can see the lung, the chest rises, so it's in a proper position. Indications of laryngeal mask airway. It's an alternative to endotracheal intubation, but not replacement, especially in emergency full stomach patients. It's a rescue device in expected or unexpected difficult airway, so you can use it as a conduit for intubating stillate, or for flexible fiber optic bronchoscope, or smaller diameter endotracheal tubes in difficult intubation. Contraindication: pharyngeal pathology, obstruction, high aspiration risk, and low pulmonary compliance. That means we need a high pressure to ventilate the patient, more than 20 centimeters H2O. It's not proper instrument for long surgeries, and the disadvantage that it can be dislodged or rotated inside patient mouth, so it's not completely protecting the airway. Now, tracheal intubation, or usually we don't say endotracheal intubation, we just say intubation, which is a placement of flexible plastic or a rubber tube into trachea to maintain an open airway or to serve as a conduit through which to administer certain drugs. There is a term called secured airway. Secured airway means the cuffed endotracheal tube is in the trachea with the cuff plated. This is secure airway. That means there is nothing, there is no foreign body, debris, secretion, stomach content can go to that airway. Endotracheal intubation, it's a task for every ER staff. It's a task for every ER staff should know how to do proper endotracheal intubation. Endotracheal tubes. Endotracheal tubes are modified for a variety of specialized applications. Of course, it's flexible, sometimes reinforced, we call it armored. There are red rubber tubes, microlaryngeal, and ray tubes, ray, nasal ray, double lumen tubes for thoracic surgery, cuffed tubes, non-cuffed tubes, in different sizes. All endotracheal tubes should have a radio-opaque line if we want to take an X-ray and see that if that tube is in its proper site. Airflow resistance. You know that the endotracheal tube is smaller than the size of the patient trachea. So, what decides the more resistance? Of course, the larger tube, less resistance. The narrower tube, more resistant. Longer tube, more resistance, and connections. More curved connections, right angle connections causes more resistance, airway flow resistance. Those are picture of endotracheal tube. You see this cuff endotracheal tube. There's a cuff and there's a pilot balloon where we can inflate the cuff. This balloon shows how much that cuff is inflated. If this balloon is deflated during the procedure, that means there is leak in the cuff. Maybe the cuffs have been teared. And this is a non-cuffed endotracheal tube. This is an armored endotracheal tube or reinforced endotracheal tube, which is used in conditions where we expect kinking. The tracheal tube will kink, especially in surgeries near patient face. Oral ray tube. Oral ray tube, that means we put this tube orally to the trachea, and this is used for nasal surgeries. Or nasal ray tube, which is put through the nose to the pharynx, then to the trachea, and used for oral surgery. What are the instruments required for intubation? You want to do intubation. What do you need? You need auto-source oxygen. You need a mean for positive pressure ventilator or endo bag. You need proper face mask. You need the oropharyngeal, nasopharyngeal, different oropharyngeal, nasopharyngeal airways, different sizes, different endotracheal tube size. Usually we have a proper size for the patient and one size smaller, one size larger. We need syringe, thermal syringe to inflate the cuff. Suction apparatus, sure. Laryngoscope blade with laryngoscope handle. And we have different blades. We will discuss this later. Macintosh and Miller. Pillow, towels, blankets for proper patient positioning during the procedure. Stethoscope to check bilateral air entry, so we are sure that the endotracheal tube is in its proper position. And capnograph or end-tidal CO2 to detect CO2. That shows that sure 100% that tube is in the proper position. Because if the tube is in the proper position in the trachea, the machine will measure CO2. But if it's in the esophagus, there is no CO2 in the stomach, and so the capnograph will measure 0. And we know that it's misplaced or it's not in the proper place. Rigid laryngoscopes, or just laryngoscopes, used to examine larynx and facilitate tracheal intubation. Examine the larynx, sometimes we just examine the larynx. Sometimes we can use it to remove foreign body near the airway. And also we can use it for endotracheal intubation. We have two types of blade. We have many types of blade really, but Macintosh and Miller or curved and straight are the most common use. Of course, both are available here in Kurdistan. Macintosh blade is curved and its tip inserted into the vallecula between the epiglottis and the tongue, while Miller blade, it's a straight blade and it's inserted where the epiglottis will be trapped between the blade and the patient tongue. And use. This is a straight Miller blade, and the other one is Macintosh, which is very common use all over the world. Macintosh curved laryngoscope blade. In this picture, we see Macintosh blade, where it's inserted between the patient epiglottis and patient tongue. While Miller is inserted below patient epiglottis, where the epiglottis is between the Miller blade and patient tongue. What are the indications for orotracheal intubation? Provide patent airway, as we said. When everything fails, we intubate the patient. And cuffed endotracheal tube is the only security for airway, for the airway, that this cuff will prevent aspiration of gastric content and all other materials in the mouth. Also, it prevents, as we said, inhalation of gastric content. Also, if the patient needs frequent suction, for example, patient in the ICU. Also, facilitate positive pressure ventilation. We want to ventilate this patient. What to do? We need to intubate him first, then put him on ventilator. Operative position, other than supine. Sometimes we have operation other than supine position. For example, lateral position. Morrison for position for nephrectomy. Prone position, that means face down during laminectomy. Sitting position in posterior fossa surgery and neurosurgery. So all these positions need the patient to be intubated, otherwise it will be difficult to maintain the airway. Operative site near or involves the upper airway. When they do nasal surgery, rhinoplasty, or tonsillectomy, of course, we need endotracheal tube. When the airway maintenance by mask is difficult, we can't maintain by mask. There is leak. The mask is not fit on patient face, so we need to intubate the patient. And when there is disease involving the upper airway, for example, a mass on vocal cord, for example, epiglottitis and edema of the epiglottis. Now, how we perform orotracheal intubation? Elevate the height of bed to the laryngoscopist xiphoid process. Of course, in this condition, the laryngoscopist is sitting. Place patient in static position, neck flexion, head extension, aligns oral, pharyngeal and laryngeal axis by putting a pillow behind patient's head to provide a straightness view from lips to the larynx. Pre-oxygenation with 100% oxygen for a few minutes. Then anesthesia drugs if needed, otherwise the patient is in deep coma and does not need anesthesia. Take patient's eyes shut to prevent corneal abrasions. Hold the laryngoscope in the left hand. You are right-handed, left-handed, always laryngoscope in the left hand. Scissor the mouth with the other hand, with the right thumb, with the thumb and the index finger, and insert the laryngoscope from the right side of the mouth, gradually to the middle, sweeping tongue to the left. Advance until the gluteus appears in view. That means laryngeal opening. You'll see the gluteus, then you'll see the vocal cord, so you know you are in the proper place. Do not use the laryngoscope as a lever. Do not press on the upper teeth. Always try to lift up and away the laryngoscope. Pressing on teeth may lead to teeth injury and fracture of teeth, dislocation of teeth. So imagine somebody comes for rhinoplasty and awakes from anesthesia with a missing teeth. It's a disaster. This picture shows how we scissor the mouth by thumb and index. This picture shows how we insert the laryngoscope inside patient mouth. Note that this is a Macintosh blade, curved blade, and the laryngoscopist tries to pull away the patient's lower lip from to not be squeezed between patient teeth and laryngoscope blade by his little finger. This picture shows when you put a pillow behind patient's head, how this will make it easier for us to see or intubate the patient. Using the right hand now to pass the endotracheal tube through the vocal cord under direct vision. So endotracheal tubation must be done under direct vision. Inflate the imperial cuff with the least amount of air necessary to create a seal during post-pressure ventilation. We ventilate the patient, we inflate the lung, and we try to hear if there is any leak around the tube cuff. Now confirm the correct place of endotracheal tube by chest auscultation, by end-tidal CO2, which we mentioned before, and by Vogue, which condensate on transparent endotracheal tube. Also by palpation of the endotracheal tube cuff and sternal notch. If the tube went too much inside, that means it's in one of the main bronchi, it will read a high peak pressure over the airway pressure gauge. So it's easy, just deflate the cuff, pull the tube little out, and re-inflate the cuff. What are the complications of endotracheal intubation? We have complication during direct laryngoscopy and intubation of the trachea. We have complication while the tube is in place, and we have complication during extubation. Now, complications during direct laryngoscope and intubation of the trachea. Dental and oral soft tissue trauma. Dental dislodgement, tissue damage, gum, blood bleeding from gums, all this may happen. Hypertension and tachycardia, especially if the patient already is hypertensive or patient already has a problem with cardiac rhythm. So cardiac dyspnea, and of course those may lead to myocardial ischemia. That means MI could happen during endotracheal intubation. And we have different methods to prevent this. Inhalation, especially of gastric content. Complication while the tracheal tube is in place. Tracheal tube obstruction, endobronchial intubation, esophageal intubation, that means misplace of endotracheal tube. Tracheal tube cuff leak, barotrauma because of over inflation, nasogastric distension, accidental disconnection from breathing system, tracheal mucosal ischemia because of long time inserted in the tracheal tube, especially in the ICU, or high pressure inside the cuff of the tracheal tube, and accidental extubation. Now, immediate and delayed complications after extubation of the trachea. Laryngospasm, again, risk of inhalation of gastric content, pharyngitis, laryngitis, tracheitis, laryngeal edema, septic edema, laryngeal ulceration, tracheal stenosis, and vocal cord paralysis also. Also, athenoid cartilage dislocation, and this happens because if you extubate the tube while the cuff is inflated. Nasotracheal intubation. Sometimes we need to put the endotracheal tube through the nose, pass to the larynx, through the vocal cord, to the trachea. Indications: intraoral surgery, for example, tooth extraction, anatomical abnormalities or disease of the upper airway. We cannot put oral-tracheal intubation. We cannot do oral-tracheal intubation, so we do blind nasotracheal intubation. When long-term intubation of the trachea is anticipated, that's when patient in the ICU. We try to keep the patient ICU on oral tracheal intubation for 1 week. Then, if need more than 1 week, we go to nasotracheal intubation. Or from the start, we expect this patient to stay in the ICU more than 1 week, so we go immediately to nasotracheal intubation. Advantage of nasotracheal intubation over orotracheal intubation: more stable tube, less chance for tube kink, greater comfort in awake patients in ICU, fewer oropharyngeal section. We can keep the patient mouth hygiene, continuously cleaning patient mouth because the tube is in the nose. Complication unique to nasotracheal intubation: epistaxis. We don't use nasotracheal intubation frequently because of epistaxis. Dislodgement of pharyngeal tonsils, especially if it's enlarged, or second tube obstruction. Maxillary sinusitis, bacteria, gastric distension. Now we go to flexible fiber optic bronchoscope. Flexible fiber optic bronchoscope is an expensive instrument. It's not available in every hospital. Indications of its use: difficult laryngoscopy or mask ventilation. When there is difficult airway management, we cannot do mask ventilation, we cannot do endotracheal intubation. Our last choice is fiber optic bronchoscope. So in any case of difficult airway management, our last choice is flexible fiber optic bronchoscope. Another indication is unstable cervical spine. Patient has cervical spine injury, and we are not allowed to move his neck. Also, poor cervical range of motion because of disease, because of rheumatoid arthritis. Also, when the patient cannot open his mouth properly, and temporomandibular joint dysfunction. And in congenital acquired upper airway anomalies, micrognathia, any other airway diseases, maybe a big mass in the mouth that we cannot do endotracheal intubation, and we use the fiber optic bronchoscope through the nose, and we do nasotracheal intubation by the help of the flexible fiber optic bronchoscope. Flexible fiber optic bronchoscope needs xylocaine lubrication during the procedure. Sometimes we depend only on xylocaine, and we don't give anything to the patient. This is a picture of the bronchoscope, fiber optic bronchoscope. This is how they insert it. Awake flexible fiber optic intubation. We have a case that morbid obese or have a CA in his mouth, or it's anticipated difficult intubation. So there is no need to go and try other method. From the start, we prepare the fiber optic bronchoscope and prepare the instrument and start intubation. The equipment needed is Airway, topical anesthesia, vasoconstrictors, local vasoconstrictors, which is usually mixed with topical anesthesia, anti-salog, that means drugs decrease secretions like atropine, hyoscine butyl, suction apparatus, and fiber optic scope with proper size endotracheal tube. We talked about the indications, and sometimes the patient needs pre-medication, sedation, midazolam, fentanyl, or ketamine. Mostly we do it without those drugs, and we do it for that reason it's called awake flexible fiber optic intubation. We ask the patient to be cooperative because there is no other way to do the airway management. Thank you. Questions?